Bonjour à toutes et à tous.
Everyone.
Je m'appelle Tristan Leloncker.
My name is Tristan Leloncker. I'm in charge of Cell 3 at MSF.
Vous introduire la partie sur les victimes.
Give you a short introduction on this session on violence and victims and the work done jointly by MSF teams and Epicentre. As you know, MSF supports victims of violence in great many countries around the world. Access to patients is something which is a true challenge for our teams. We always try to
par exemple, les survivantes, les survivants de victimes de violences
pathways to survivors of SGBV, victims of sex-based and gender violence, and while positioning our teams and guaranteeing their security. Of course, it's top of our mind, and very often it's very difficult to document and assess on the basis of facts, the consequences of this level of violence on our patients and our teams. In order to answer this question, this interrogation, MSF Operations and Epicentre have come up with these surveys we're going to tell you about, and more particularly, it's something which has been driven by the emergency teams and Cell 3 in Dakar, which I'm representing. I'm going to give some time to Jean-Guy to tell you more about the Epicentre study that was carried out in Gaza. However, on my side, I'm going to give you a short summary of mixed method approach study that was commissioned by Cell 3 and which was carried out by Epicentre before opening in Mauritania. Cell 3 is based in Dakar. We worked with Epicentre on an innovative approach, both qualitative and quantitative, in order to shed some light on violence as experienced by refugees fleeing Mali to reach Mauritania. As you probably heard, this conflict in Mali has now touched Burkina and Niger, and this conflict has led to massive IDPs within the country, of course, but also refugees fleeing the country and fleeing to Mauritania. Now, this is the situation of violence that prevails in Sahel, and our teams in Tenankou, at the very heart of Mali, they had to treat some 10 people who had been attacked by drones just outside of Tenankou. Let's just give you an example of the level of violence to which these people are subjected to in Mali in particular, but in Sahel at large. There were several incidents of this type, and therefore in 2024, Cell 3 decided to start an EXPLO mission to assess the situation of these refugees from Mali to Mauritania and to better assess the level of violence for these populations. So we worked on these two aspects with Epicentre. The quantitative survey gave us access to reliable demographic data, which is a major issue. It also shed some light on vaccine coverage, mortality, prevalence of malnutrition, so as to get some sort of epidemiological compass to guide us through our activities and for our operational strategy. Now, the second part of this work is the qualitative aspect and the capacity for Epicentre to document violence and to help us to better understand the situation of these people, not only when they flee their country, but also on arrival in the neighboring countries, is to better design our response to and our care for these people. And it also tells us a lot about the health status of these people in the area of Mauritania where we work. I'm going to give the floor to Gaston and Pascale. Thank you very much to both of them for their work and their commitment. They were with us in Mauritania, and so let me hand the floor to them.
Bonjour à tous.
Hello everyone. We are going to tell you about this mixed method approach to describe violence and mortality among Malian refugees and host populations in Mauritania in the Bassiknou district. Now, for more than a decade now, the Sahel region is faced with a high-level security and humanitarian crisis. Because of insecurity, several families had to flee Mali to reach Mauritania. The first waves of refugees arrived around in 2012, and the latest waves started in August 2023. They are in the camp in Mbera. Now, there are several questions or issues. You see, the majority of interventions are limited to Mbera, the Mbera camp. So we wanted to know more about the people who are refugees but outside the camp. The main objective is this one. We wanted to describe and also put in perspective, to contextualize mortality and experiences of violence among Malian refugees and in the host population, the host community. In order to do so, we had secondary objectives, i.e. estimate the size of the refugee and host populations in villages hosting refugees, also calculate crude mortality rate, CMR, and also under 5 mortality rate, and identify main causes of mortality, and also review the types and frequencies of violent events among refugees and in the host community.
Pour la partie quantitative,
now, the quantitative methods is designed as such. It's a retrospective survey with 2-stage cluster sampling. And we targeted all refugee hosting villages in Bassiknou district with exclusion of Mbera camp. All family members during the recall period from August 2023 to January 2025 were taken into account, which gives us a period of 17 months for recall. And we used GIS. The GIS team helped us to count the shelter roofs, and we ended up with a random sample of 126 clusters. Between the January 6 to 18, 2025, we gathered a sample of 828 families, 4,511 individuals. 18.9% were refugees. However, there is an underrepresentation of men aged from 20 to 24 among the refugee population. In order to get population estimates, we have decided to include 2,653 geolocated shelters among the 37,317 shelters from the GIS survey, so that it gives us refugees 17.9%, host community 82.1%, with an average number of people per shelter, of 3.1 in the community, 4.5 for refugees. Now, we then ended up with an estimate for a population of 29,739 refugees, 692 returnees, and 94,898 residents or community individuals. This is to assess mortality. We express this in the number of deaths per 10,000 per day during the recall period. And we could see that the CMR was twice as high among refugees versus the host community. However, if you take a closer look at men, well, among men in the refugee population, it's 3 times higher versus the host community. On this map, you can see in green Mali, in orange Mauritania, and the circles are proportional to the number of deaths per site. Red for refugees, purple for host communities. We can see that two-thirds of refugee deaths were recorded while still in Mali, and 4 deaths out of 7 for refugees are associated with violence. And in order to try and assess the level of violence, we calculated the violence incidence rate, accounting for the number of violent events per 10,000 per day during the recall period. In fact, this rate is 5.9% for refugees, versus 0.5 for the host community. And it is important to note that the non-response rate is 3 times higher among refugees versus the host community. On this map, you can see the geographical distribution of violent events, violent episodes, and Mali in green, Mauritania in orange, and the circles here again are proportional to the number of events per site, and refugees are shown in red, purple communities and returnees in purple. One can see that these violent episodes reported by refugees took place in Mali, and therefore the security level is higher for refugees as soon as they can reach Mauritania. Now, looking at the nature of the violent episodes, well, violence is reported by refugees while in Mali, and the sexual violence cases are originated from the host population. And here I like to hand over to Pascale to give you more detail on the qualitative component of our study.
Merci Gaston.
No, thank you very much, Gaston. Hello, everyone.
Donc, pour la composante qualitative.
Now, this qualitative component was performed in 3 sites in the district of Bassiknou, guided by the outcome of the quantitative study, while making sure to get enough diversity, both geographical and social, for participants. We included the rural area of Matlé, and it's close to the border with Mali, and also the semi-urban Douengara site and the Agor site, which is the location of the former refugee camps, where communities live separately. We have used the peer method, which is participatory ethnographic evaluation and research approach, taking advantage of the local researchers and their trusted relationship with their communities. So we train these peers and trained supervisors. On the quantitative component, they could help us with reliable translation, with contacts, with the easy contacts to the communities, and implementation of the study. And following mapping, we conducted community-based consultations with the authorities, representatives of the key stakeholders, in order to introduce our study and also to call on them for the participation, for the identification of peer researchers among the community. So we selected these peer researchers, PRs, with a number of criteria. We didn't want them to be in positions of power, and also to be then we trained them for 2 days in the language of their choice, with an interactive training system based on their literacy levels. This was variable and targeted towards the collection of qualitative data and also ethical issues. After training, we asked them to conduct interviews with the participants around 5 key issues. Then we organized individual debriefings of these PRs for narratives, for feedback of the interviews. We documented this with executive summaries and also audio recordings with counseling services offered to these PRs. This is to help them to manage the consequences of having led the interviews. Then we organized community workshops for feedback open to anyone, all members in the community. This was organized by the authorities, with participation of PRs, MSF and MOH representatives, and we did so for approximately 6 weeks. Now, our results, we worked with 31 PRs who conducted interviews with 68 participants aged 20 to 83. In these 2 groups, there is a well-balanced composition with participants from different communities, Tuareg refugees, Fula refugees, Arab refugees, and very often the criteria put forward was to answer the questions of PRs were the fact that they trusted them and considered that they were honest, and also they wanted to report on the violence experience. Now, when you look at the interviews, you can see that there were attacks conducted by armed groups with arbitrary executions by firearms, beheadings, hangings, people burned alive, sexual violence, torture, beatings, kidnappings, rape. This violence was targeted mainly towards men and young boys, but with also extreme violence against women, pregnant women, and families. These acts were committed in public, and of course it was a source of terror for the population. Many testimonies of loved ones murdered and or assaulted were seen, with few accounts of direct violence. In these reports, you find also looting and destructions, thefts, also repeated violence, repeated threats, and all this forced the population to exile. Now, fleeing to Mauritania was often done hastily, leaving everything behind, dangerous journeys over several days with many episodes of violence along the road, and also the risk of violence that was felt up to the border, meeting our patrol rifles and drones along the route with random searches, robberies, executions, arrests, and kidnappings.
Alors, arrivé en Mauritanie, les participants rapportent.
Once in Mauritania, participants report that the violence is still felt psychologically and physically, with intrusive thoughts, depression, anxiety, sleep disorders, social isolation, an ability to speak, also psychosomatic pain and reproductive consequences, with several spontaneous abortions and neonatal death or maternal death that were attributed to the trauma provoked by the violent episodes. The living conditions in Mauritania are difficult, and with an added burden for these refugees, with economic precarity, food insecurity, limited access to water, poor healthcare access, inadequate service availability, and a lot of these people have to beg, or they are indebted. And of course, all this is a burden on these populations of refugees. But it's also a burden for the communities, host communities. This is an economic strain, and their incomes decline. There's also increased competition for basic services such as wash and healthcare. And of course, this does contribute to intercommunity tensions, and it is a threat to long-term peaceful coexistence. So in our study, we could see that there are significant differences between the host communities and the refugees. The refugees are more often exposed to violence, and they also experienced extreme violence episodes during their journey, and this of course is also combined with precarity once in Mauritania. We think there is an urgent need for multi-sectoral interventions to respond to the acute psychosocial vulnerabilities and critical needs among refugees and host communities, with food, water, safe shelter, livelihood, protection, access to healthcare, mental health, sexual and reproductive care. With this participatory mixed method approach, we think that we were able to quantify and also put in context the patterns of violence and violent deaths, and amplify community voices. There were, of course, limitations, but we could highlight humanitarian priorities to inform advocacy and provide actionable operational recommendations. We would like to thank very sincerely the communities of the Bassiknou department, the peer researchers, the study participants, and the communities that participated, and also the MOH and MSF and Epicentre teams. Thank you.
Bonjour. Je m'appelle Jean-Guy, je suis chef.
Hello, my name is Jean-Guy. I'm head of mission in Palestine. I'm going to tell you about a study that we conducted over the past few months in Gaza. Well, I don't think I need to introduce the situation, but there are two characteristics that are noteworthy to explain the context of the study. Well, firstly, the conflict is taking place on a very small territory, from which the population can't escape. And there are several, there are repeated shell explosions, and the number of deaths published every day by the Palestinian MOH are reliable. Sometimes these figures are called into question by the Israeli authorities, but widely accepted around the world. This population is also faced with the destruction of schools, hospitals, roads. According to WHO, 94% of hospitals are destroyed or damaged. 19 only out of 36 can still treat patients, and only partially. And it's even less than that over the past few days. MSF asked Epicentre to conduct a study in Gaza to identify the impact of repeated displacements on access to healthcare for the population, and also to assess mortality, not really to confirm or call into question the MOH figures, but also to get an estimate of violent death. And every day, these people are faced with very difficult situations, very dangerous situations. So you can't really send out a team of interviewers, and this is why this was done remotely. And our sample of population is well known to us, because these are people who work for MSF France in Belgium, and their families.
Nous allons vous présenter la
or related families. We are going to share with you the only part that has been finalized yet, and it's for MSF employees and their families.
Introduced presenter for this study, Jomaa Younis. He is the operational research epidemiologist for Médecins Sans Frontières in Gaza. He has a PhD in public health. His research focused on non-communicable diseases, mental health, and nutritional epidemiology. He was the principal investigator and published on a number of clinical and epidemiological studies. Jomaa, can you hear us?
Yes.
Oh, hi.
Yeah.
I give you the floor.
Thank you all. It's my honor to be with you today. Today I will present the study entitled Mortality, Morbidity, and Access to Care among MSF staff and families in Gaza occupied Palestinian territories. The conflict began on the 7th of October 2023 until the ceasefire was taking place from 19th of March 2025, and the war resumed on the March 18. The survey covered only the period up to the ceasefire. As of May 2025, the Gaza MOH reported more than 54,000 fatalities and more than 123,000 injuries. As you know, MSF responses focuses on supporting hospital and BSC and providing water and sanitation. The main objective of the study to estimate the crude mortality rate and major causes of death among MSF OCP national staff and family members living in Gaza, occupied Palestinian territories since the beginning of the current conflict. Our secondary objective is to obtain an indication of major injuries, recent illnesses, and major chronic disease, access to care, and access to obstetric services. We did a cross-sectional retrospective mortality survey with all MSF staff who have been under the MSF contract at some point since the beginning of the conflict. As a household member, we consider everyone living in the household 1 week before the war and only included birth during the recall period. The data were collected were done from the 29th of January until the 26th of March, mostly during the ceasefire. The total staff included in the survey was 436 out of 443, with a response rate like 98%. The total number of household members is more than 2,500 people with a median household size 6. We asked the household member how many times they changed their location. The median was 5 times during the current conflict. During the survey also, 41% reported to live in a tent and 23% in a rented house. 59% of MSF household, they reported complete destruction of their houses, and 39% of MSF household they reported partially destruction. On the right side, you see the survey population in color by age and sex, with the female in red color and green for the male. The black outline indicates Gaza population distribution from the census in 2017. You can see that both distribution are pretty similar, with MSF household more old people and less young people. The overall mortality rate for MSF household was 0.41. The mortality rate was higher for violence with 0.33 compared to the non-violence death. For under 5, mortality rate was 0.7, which was also higher for the violent compared with the non-violent. The total number of deaths among MSF household were 54. Violence was the most dominant cause of death, with 74% who died overwhelmingly due to the blast. The remaining 26 were non-violent deaths, such as those from chronic disease and neonatal death. For the death by the age and the sex, on the left side, you see the distribution by age and sex of the non-violent death, and on the right side, for the violent death. Children under 10 years old show the extreme burden, accounting for 40% of violent death in MSF household, while the 36% were between 20 and 50 years old without any difference in gender. To look at the death over the time, we divided the time from the start of the conflict until the ceasefire by 3 equal time period, 156 days. The mortality rate for the violent death was highest during the period 1 and were the lower in period 2 and 3. In contrast, for the non-violent death, increased over the time. For matching the survey deaths with MOH data, since the beginning of the conflict, Gaza Ministry of Health periodically released the list of violent deaths. MOH list and survey deaths compared by ID, name, and age and sex. From the 40 violent deaths in this survey, for the 33, there was national ID number reported by the household members. We found 29 of those deaths in a MOH list, which equal 88%. And there is no non-violent deaths were identified on the list released by MOH. For the injuries, among the included households, 7% reported having been injured at least one time during the recall period. 91% of all injuries were caused by blast. The most common type of injury was burn and soft tissue wound, with the 58%. 73 acceded care, mostly hospital and field hospital. The main reason for not seeking care, immediate death and distance and security. We asked the participant about the illnesses in the last month. In the last month before the interview, 44% of MSF household reported acute illnesses. Among all diseases, the most prevalent illnesses was upper respiratory tract infection with 27%. 95 of MSF household have had access to care for the acute illnesses. For the chronic disease, the prevalence of chronic disease among MSF household was 15%. 70% reported one chronic disease and 30% report multiple chronic diseases. The most prevalent disease was cardiovascular disease with 46%, followed by diabetes mellitus. 68% of MSF household member with a chronic disease reported treatment interruption. The median number of interruption was 2, and the longest interruption was 60 days. For the pregnancy, among women between 15 to 49 years old included in the survey, 13% reported at least one pregnancy reported since the beginning of the conflict. 100% delivered in a health structure, hospital, or BHC. There was 6 spontaneous abortions were reported. The 3 neonatal deaths resulted in the overall neonatal mortality rate of 42.3 per 1,000 live births. For the conclusion, as we mentioned, 74 deaths due to the violence, equivalent 1.6 of MSF household member. 40% deaths caused by violence were among children under 10. We notice increasing trend of non-violent deaths related to deaths over the time. We compared our result with the MOH pre-war level estimates. The mortality rate was 5 times higher than the pre-war level. The under 5 mortality rate was 10 times higher than the pre-war mortality rate, and the neonatal mortality rate was 6 times higher than the pre-war mortality rate. We noticed there is a concurrence between survey and Gaza MOH list for violent death, and there is no evidence of other non-violent deaths included. 20% of MSF household had member injured from blast or gunshot. We noticed also good access to care for MSF household. 2 to 3 with chronic disease experience 1 or more treatment interruption. Actually, we have the limitation that this study not representative of the general population. And the last thing, this survey does not reflect the recent escalation of the violence since the end of the ceasefire. I would like to acknowledge our participant, MSF staff in Gaza. Those did an incredible job during these difficult circumstances. Our data collectors, all co-investigators, our team in Gaza and Jerusalem and Paris and Epicentre. Also, as a research team, as MSF, and as a civilians, we call for urgent ceasefire. Thank you for your attention and listening.
Thanks a lot, Jomaa. Okay, so now it's time for question and answers. On va peut-être donner la priorité aux personnes qui sont dans la salle. On va prendre peut-être 3 premières questions et puis ensuite on regardera en ligne.
We'll take first 3 questions, then we'll check the questions put online because we only have 10 to 15 minutes for Q&A.
Bonjour, Anthem Seka,
Hello, Anthem Seka, I'm a doctor in Dakar. One concern in terms of violence in Bassiknou. In your presentation, we realized that there is practically no sexual violence among the refugees. Does that reflect some difficulty that the peer researchers had, or is it due to the stigma experienced by the women? So there is no estimate of sexual violence amongst refugees?
Ouais, peut-être, ouais, on va enchaîner. Comme la question est un peu longue, on va peut-être essayer d'y répondre directement. Ouais, si ça vous va.
Ok, je vais commencer et puis je vais passer la parole à Pascal.
I'll start and then I'll hand over to Pascal. Actually, in the quantitative component, we had 0 case of sexual violence amongst refugees. That's one of the reasons that urged us to design this mixed sequential approach, starting with a quantitative survey to try and analyze on a big scale the various challenges the refugees were faced with, but combining it with a quantitative component to explore in a deeper way the sexual experiences. This qualitative approach was essential because often these experiences are underrepresented in the quantitative phase because what people experience has quite a complex impact on the individuals. It It can also lead to collective trauma. And it has to do with the very sensitive nature of the topic, which calls for a rigorous ethical approach, delicacy and cautiousness. You have various contexts locally that may account for the fact that we didn't find anything about sexual violence amongst refugees. Well, first, it's kind of a taboo subject. And in Bassiknou, sexual violence is penalized. So if the victim confesses she was subjected to sexual violence, she can be prosecuted. So it's pretty tricky, really. In addition to the quantitative phase, during the quantitative phase, we had to prepare the investigators so they would be very tactful in collecting these data. And the few cases we collected amongst the host community took a lot of tact. But in the qualitative phase, since it was with peer researchers, people from their community, people they could trust, they were able to express more easily any case relating to sexual violence. And some were subjected to sexual violence, but they reported it as someone else having been subjected to sexual violence. And that's how we were able to collect some data. I think you said it all, but true, great efforts were put in the quantitative aspect of the study to collect that type of information. But as Gaston said, it's very touchy, very sensitive. We tried to get female investigators to collect those figures. We also worked with the female head of reproductive health at MSF. We had nothing in the quantitative phase, and only in the qualitative phase we got some accounts, but third-person accounts. The participants were known by them, but completely anonymous. That was the only channel for us to collect this type of violence amongst refugees. Also, during the interviews, we found that some topics couldn't be shared with foreign people. In some cases, a woman who was subjected to sexual violence might talk about it to the women in her community or her peers, but not to a person outside of their community.
Thank you. Maxime Anguès, University of Lincoln. Thank you for the excellent presentation. I had a question for the last presenters. So I understand that your result is not representative of the general population, but from your understanding and also maybe access to others' data, do you think in the general population they are more likely to be victim of blast than MSM, or if it's just that MSF staff, because of their activities, they are more exposed to this kind of wound? Thank you.
Yeah, thank you for your question. Actually, you know, if 1.6 of the violent deaths among MSF group, with 74% of violent deaths, I think this is still among the general population. And you know, the general population, it's more suffering than the MSF staff. As MSF also implementing the duty of care and solidarity department, and they are supporting their teams, and they have more accessibility and the communication channel to access to care, to be more like notified, to be more protected. Yeah, my answer, yes, the general population, it's more affected than the MSF staff.
Hi, my question is for Jomaa. Thank you for your presentation. Maybe just a small comment. I appreciate that the data that you presented today is extremely important as a témoignage for the horrors that the occupied Palestine territories are enduring. but also as a kindly reminder that our staff, our colleagues, and their families are not just numbers. So thank you so much for this super relevant presentation. And my question would be, how is MSF using this information, if it is given any use, to urge international actors into a ceasefire and letting humanitarian aid into Gaza?
Yeah, actually, we hope that this result can be used and can help for MSF to advocate in the international community for the ongoing conflict and the high number of like deaths. It can help also to adapt our activity, and it can be invested in supporting our teams as well.
Thank you, Jomaa. Peut-être William, tu peux compléter, directeur des opérations.
Thank you, William. Now,
I think there is a similar survey ongoing as well. We are discussing about the timing with which we want to to make this survey public, but it's for me an additional piece of all what we've been putting on the public domain since the start of the war. And it's an important one, and I think we may learn additional information with the second part of the survey. So yeah, we still discussing how we will best use it.
Hello. My question is for Mauritania. I would like to, thank you very much first for your presentation. I would like to ask which were the main challenges or barriers regarding the methodology that you used, and also if an increase on awareness and access to care was noted afterwards regarding survivors of violence. Thank you very much.
I'm sorry, I can't see you. Can you? Oh, okay. So in terms of challenges, I think number one was the timing, because we were sort of pressed to have results for the project. So it was quite intensive, and I think even the supervisors worked really hard. We were working every day. We received great support from the communities, but even the identification of the peer researchers was somewhat a bit difficult, sometimes a bit political. So I think the challenges were a bit challenges that you have when you work with communities, like to navigate, sensibilities, maybe political issues. So that was one of the first one. And then it was the training was fine. I mean, we adapted because we realized that initially we wanted to have people who could read and write, but we realized that then we would exclude some people. So it was really to adapt the training to people who could not read and write necessarily. And your last question, so it was challenges, and in terms of access to care, so the great thing is the project has some both mental health activity manager and reproductive health activity managers. So we discussed a lot with the peer researchers who themselves discussed with the participants about the services that were available. So I think we don't have the numbers, but I think it has increased access to care, yes.
Thank you very much. I think I speak on behalf of so many of us that this is very important work, but very difficult work. I don't know how many of us would be able to present this kind of work. The amount of, the kind of stories and the kind of experiences that you're relating. And so I just want to know what was done for the research teams, that went ahead to collect this data that regards a lot of violence and death and pain, and so that they can be able to, both of you, like what was done for the research team. Thank you very much.
Maybe we can also include Jomaa in the answer first.
Yeah, actually, from our side, for the research team, since the beginning of the data collection, we make sure that our team in contact with the BSU team, and they are doing routinely debriefing with the team. Some of them they did daily session, and some of them weekly session, and they did debrief. And I will take the chance to thank our BSU team in Amman and here in Gaza for their support for our teams. Yeah.
Avant de compléter la réponse, on prendra une question après cette réponse et après on devra...
Okay, we'll complete the answer and then we'll take one more question and we'll have to stop.
Sinon, vraiment, comme vous l'avez dit,
as you said,
c'est un grand défi.
It's a major challenge to carry out a survey on violence with investigators and researchers who are likely to be victims of violence as well. And we had to take that aspect on board from the very onset of the survey. When we did the quantitative phase, we worked with the supervisors. We picked 2 refugees and 2 people from the host community to have a balance, even with the investigators. So in the preparatory phase, we realized that amongst the investigators, even supervisors, some were victims or they were witness of cases of violence. And just the memory of that does have an impact on them, even before collecting data in the field. So we strove to involve the psychological counselor of MSF for the quantitative phase. And she had time to explain to them how to collect the data and how to work through the management of trauma within our own team, so that some investigators had scheduled sessions with the psychological counselor because they had to be de-traumatized, as it were, before going to the field to collect data. And it was a great help. When they went to collect data in the field, we saw they would apply the right methods, good methods, to interview the refugees or the people from the host community. They were really apt at doing it because they were trained. And for those cases they identified who needed support, they were referred to the psychological counselor as well. And we noted that they were extremely tactful. So it kind of dampened, the traumas. But even in the qualitative phase, we continued that type of psychological follow-up. Even with the investigators, while preparing the qualitative phase, we would have meetings talking about how to approach those issues with the community. And one was close to tears, just remembering all the accounts he collected. But that is something not to be overlooked. It's not machines collecting data. They are human beings. And so you have to take that into account among the researchers as well as the beneficiaries, of course. And if Pascal would like to add, well, you said it all again, but yes, we did get lots of support, great support from the head of mental health department of MSF. The whole research teams was greatly affected. All the members were greatly affected. They themselves experienced violence, or people they knew, or their relatives were subjected to violence. There were some sessions where collectively did help some people, though, to talk about it. But some researchers told us that the mere fact of discussing it with the participants or with the peer researchers did help them. So it was like a collective healing almost. And the trauma was experienced by a whole community, and working on that collectively, working through it, did help them. Hello. Well, first, many thanks to all the research teams for your great work. It's very interesting to see how well you conducted these studies, and those surveys help us to quantify and gear humanitarian operations. You responded for Gaza, but my question is for you, Tristan. After this survey in Bassiknou in Mauritania, what does MSF do to respond to the needs of the refugee population in Mauritania? Thank you. There are two aspects here. First, what we want to do with our operations, and then the other part has to do with advocacy. And what do we do with all those accounts and testimonials about violence and what our patients experienced. Operationally speaking, the Epicenter survey allowed us to reposition our entry points along the border between Mali and Mauritania, because we got to understand better what the flows were of refugees or returnees. Second aspect, it helped us to organize a more holistic approach to taking on board mental health components, access to healthcare in general, and also the environment, the surrounding environment. We talked of access to food, access to water. Thirdly, I believe that the way investigators, particularly peer investigators in the qualitative study, the way they approach the people in the community and collected testimonials, it helped us to better understand how we should organize the care we want to provide to these people. Initially, we had mobile clinics that roamed frequently in different locations, but then we realized we were not close enough, we were not doing outreach enough. We had to do more outreach, and the way the peer investigators worked opened our eyes to that. So we decided to have fewer sites, to be more anchored in the communities for a better outreach. Regarding testimonials and advocacy, we are reflecting on the way to communicate all that. The difficulty is to share those testimonials without exposing our team members, without creating a diplomatic incident, because we are present in Mali as well as in Mauritania, and there can be differences in perception about those testimonials. So we are in contact with the whole ecosystem of journalists, NGOs, and NGO human rights testimonials about human rights. We haven't fine-tuned our strategy, but we are moving forward on that. Okay, let's give a round of applause to those great people who conducted those surveys.